The HSJ Health Check Podcast is sponsored by Cisco.
Hello and welcome to the HSJ Health Check Podcast, where each week we bring you expert insight and analysis on the biggest issues in health policy and the NHS. I'm your host, Annabelle Collins, and this week I'm joined by Senior Correspondent Rebecca Thomas, South Eastern Ambulance Services Specialist Correspondent Alison Moore, and Employment Reporter Nick Kituno. So this week on the podcast, we're going to be focusing our discussion on the NHS workforce. Before COVID came along, the workforce was certainly the main concern for most NHS leaders. And as we head into the winter and a potential second peak, we thought it was time to dedicate a podcast to discussing some of the issues facing the people who will take much of the strain over the next few months. As workforce correspondent at HSJ, I do try to regularly touch base with frontline workers, and over recent weeks, I've been told of an increasing sense of anxiety as COVID cases begin to rise, A&E departments begin to fill up, and there's an overwhelming backlog of cases and clinics to get through. One doctor working at a large acute trust told me just the other day that working acutely, we're starting to see coughs and colds and exacerbations of asthma that come with a change in the weather. Despite the fact people have been desperately making preparations for a second wave and the difficulties winter will bring, I'm incredibly fearful of further disruption and cancellations in the coming months. And just last week, we held our virtual HSJ Workforce Forum, and I was struck by some of the issues raised and wanted to discuss these with podcast listeners. In particular, we held a really memorable session on where we heard from frontline NHS workers who described kind of the turmoil and stress and kind of unprecedented working conditions they experienced over the peak, and kind of real concerns about whether they'd have it, whether the workforce would have the capacity to cope with another surge in cases. So during the summit, there was a real focus on staff wellbeing, recovery and support, which were of course really welcome, but I did feel that there was a slight lack of engagement with some of the senior speakers on things like pay and also workforce numbers, as vacancies are ever so slightly rising, but it's quite difficult to compare year from year during kind of COVID and non-COVID years. In the very first keynote session, I was kind of interviewing Prerna Isar, NHS England's Chief People Officer. I asked her about the second and arguably more important people plan. And I think it's fair to say she dodged that question a little bit, but she did hint that there could be some slightly tougher negotiations to come in the autumn.
Well, aside from dodging your questions, did she give you any insights on the future workforce spending?
Well, not really. She sort of just said that Health Education England had put forward recommendations, and I think the phrase she used was plans for the consideration to the government in terms of investment. But she mentioned the word trade-offs, which I sort of kind of set an alarm bell ringing a little bit for me, because it reminded me of an interview I did with David Bean, probably about 18 months ago now, where he talked about there were trade-offs when it came to HE's CPD budget. When it was cut, and I was sort of thinking, well, what are these trade-offs going to be? But there wasn't really too much more kind of insight on that. And she also kind of touched on recruitment processes and the need for the NHS to be inclusive, and we're going to touch on this, I think, kind of later on in the podcast. But it felt like there was just kind of a lack of engagement with those kind of more challenging issues of, I suppose, finance. All depends on the spending review at the moment.
I mean, that's been the excuse for a long time, right? We couldn't get any proper people plan figures because of the spending review. That's been the excuse for like the past year or so.
No, I know, yeah, absolutely. And I think as well, we've been waiting for, in the interim workforce plan, which came out in June 2019, people were kind of expecting more in that, but the argument all along has been we're waiting for the spending review. But obviously COVID kind of tipped everything on its head again. Spending review is now expected sometime at the end of this year. That's still kind of unclear. I mean, I don't know. I wouldn't be surprised if things were maybe pushed back further, but I mean, I think that would be quite difficult for NHS leaders and other kind of workforce planners to stomach at the moment.
You got that scoop week before last about the international recruitment, so clearly it seems gunning for international recruitment is part of the plan despite COVID right now.
Yeah, no, absolutely. I think it was actually quite. I mean, I wrote a few stories kind of earlier in the summer around the fact that they weren't going to amend any of their workforce targets, and international recruitment was still going to be like the biggest lever of staff coming over to work in the NHS and kind of bringing those, particularly those nursing figures, kind of hitting the 50,000 that the government wanted. And there wasn't really any movement on those targets. I think there was kind of an acceptance that they'd need to be backfilled. But yeah, the story you're referring to is sort of, I think it said that trusts collectively, so not necessarily individual trusts, but collectively need to aim for a 41% increase in international recruitment. And in the same week, I was kind of looking into issues in the Philippines, where there were hundreds of nurses who couldn't come over, and there was a lot of confusion about what was going on. I think now Alison knows about this too, but it's been resolved. But it just the two stories were just kind of completely contradictory, and I don't know. It seems like a very. I mean, it's good to be optimistic, but it seems like a very ambitious target to set for trusts at the moment.
I have heard of some trusts that have successfully managed to bring in staff from overseas, despite all the difficulties over the last few months, but obviously not many. And I suspect there's maybe a reluctance for people to travel as well. I don't know if you've encountered this, Annabelle, whether Britain is now seen as being a rather high-risk place to go to work. I'm sure some of the publicity around the terrible toll of deaths amongst the Filipino community here must have paid back.
No, absolutely. I really think so. And I think the thing that speaking to people at HEE before all of this happened, the thing that they felt they could really offer staff were training opportunities. That was the sort of the flag they were flying about why you should come to the NHS, kind of the learning it offered and all those opportunities. But as we know, training is probably, in terms of workforce, is the thing that's taken the biggest dent. Not the biggest dent, but one of the biggest dents over the last few months. I mean, I've heard of doctors who are unable to progress to become consultants because they've not hit the right competencies. So obviously all electives were cancelled. So I think I think that's totally right. How appealing is the NHS as a place to travel thousands of miles to come and work in now? I'm not sure.
And was there any sense at last week's summit that actually things could be even tougher this time round with COVID, that staff have worked incredibly hard over the last 5 months or so and are probably feeling fairly shattered? And doing it all again is not much fun.
No, I think that did come through, but I think it was sort of the toll on kind of the physical health, obviously, and staff suffering from long COVID and kind of symptoms of COVID that have been lingering. I speaking to somebody the other day, they said they had staff members who were would come and try and work and they just couldn't because they were so exhausted. It's a real problem, and I think I really hope that I hope the long-term impact on staff in terms of the physical effects will be recognised. But yeah, there was the mental health as well. So I think it was Dr. Sonia Walbeck from NHS England who kind of leads on kind of the cultural transformation, very much involved in kind of staff wellbeing. She was saying that staff kind of talking to staff members should be the thing that's prioritised during the next phase, and kind of checking in on them and making sure they're okay and kind of prioritising their well-being. But then I kind of wondered how that translates to reality. So she talked about staff who had to, because all their kind of usual places they go and pray were all closed. Staff were having to go and pray in the hospital toilets, which is obviously a horrible thing to have to, to somebody to have to do. But she was talking about that shouldn't happen again. And I was sort of, even with the best intentions, how do you kind of protect staff well-being if things do get as hairy as they were in April and May? I don't know, to me it kind of seems a bit impossible.
It's an
Of course,
interesting one. I was so that the well-being end of it almost seems slightly more difficult than if you were to offer specialist mental health care. Like if you're, it's almost easier to make IAPT available to your staff, for example, than it is to tackle the well-being end of their mental health. For example, humane hours, certainty with PPE, and those were the things that research early in the pandemic showed were the actual important things to staff's mental health during the pandemic. I mean, then you've also got to think of the long-term effects after this is all over. But now currently in this situation, it's those, such as you said, finding a place to pray, somewhere to actually have a break. That actually has the impact in the situation, and those are potentially harder. I don't know what you guys have seen across your other trusts.
No, I think they're really hard, and I think there has been some kind of national money put towards staff wellbeing support, and it goes up in stages in terms of the support offered. But people have been talking a lot about kind of PTSD and this being something that staff aren't going to be able to shake off over weeks and months. I mean, some people have had a very different experience, kind of depending where you are in the country, of course. Like it's, the whole of the NHS workforce is by no means sort of a homogenous entity. But yeah, I agree, Rebecca. I mean, I don't know, you obviously cover mental health for HSJ, but how is the experience at mental health trust kind of, do you think, perhaps differed from acute trust? Do you think they felt that kind of that same pressure and kind of anxiety?
Yeah, so it would be obviously a different situation if we're talking about let's take inpatient mental health services compared to an inpatient acute services. You're obviously not getting an influx of COVID patients, but equally your wards have to be you have to maintain infection prevention control on your wards, so you can't really effectively communicate with a lot of patients. Your capacity might be cut down by 30%. So for those managing services, you'll have people needing admissions, and people needing, particularly going into winter. I was having a conversation recently, admissions increases are going right back up for mental health. So you're having to deal with that pressure because there isn't the physical capacity to actually treat people as well. So I think obviously it's a different experience, but I think it's equally as intense in terms of the worry and uncertainty, if that makes sense. I'm saying that I don't work in either, obviously. I obviously perhaps, and this is me presuming here, mental health trusts might be more aware of the mental health needs of their patient, of their staff. I don't know if that's necessarily true, though. To be fair.
No, I think that's a fair theory. I think a lot of trusts, like I've spoken about this before on some podcasts, but the fact that COVID sort of accelerated all these things that people have been kind of calling out for years, that working in the private sector, I think you completely take for granted. But like really, really simple stuff like access to hot drinks, and parking, and all the usual things, but just kind of making your day-to-day life easier. And I mean, it's been quite sad actually to hear about some of these things have sort of slowly started to disappear and kind of ebb away. It's sort of a shame that sort of appreciation and yeah, kind of looking after staff couldn't have continued. There was another kind of big staffing issue I think it would be good to talk about kind of before we move on to talking about kind of res and diversity, and that was around staff testing, and we published a story after the event actually with Prerna, who sort of denied that there was a problem with staff testing, which I think is now the story on the HSJ website has I think now got around 50 comments, which is definitely the most I've seen in recent weeks. That's obviously really hit a nerve, and you can understand why. I'm sure you guys have seen the same, kind of so many tweets from people working in primary care, secondary care, all bits of the NHS unable to get tested. And Alison, I noticed that you were tweeting about this yesterday. What kind of thing have you heard about this?
Yes, well, I think there's two issues really. First of all, there's NHS staff who believe they may have contracted COVID who can't get tests themselves. And I know this has been a concern for NHS providers. They've suggested that that's impacting on service recovery and also preparations for winters. And also the Royal College of Occupational Therapists has come out and spoke about their concerns today. We saw stories last week in some of the media about the length of time it was taking for doctors to access tests and for them to get the results back, for example. But I think there's another looming problem here, which is really around schools. We know that a lot of NHS staff have school-aged children, and at the moment, about 1 in 20 children are apparently off because of COVID, not necessarily because they've got COVID themselves, but because a classmate has, and then the entire class is sent back home for 2 weeks. Obviously, with young children, that means there has to be a parent at home to look after them. So I think we're beginning to see healthcare professionals who can't get to work because they've got a 7-year-old at home who obviously can't be left all day. And I can see that it's going to become quite an issue as we move forward. I'm hearing that some trusts have substantial numbers of staff off, and I was told about one trust in the Midlands that had 160 staff off last week for COVID-related reasons. And that really begins to bite at your ability to get back to anything approaching normal.
Yes, absolutely. And I've kind of heard that trusts have been kind of putting out for more and more locums, and which is quite interesting, seeing as there's a lot of pressure on them to reduce kind of locum spend. I think now it's kind of inevitable that it's just going to raise again with all those vacancies, all those people off even. But yesterday, I think Matt Hancock, when he was speaking in the Commons, didn't he say that NHS staff would be the kind of the prioritised for testing?
Yes, I think they're the top priority under the new prioritisation regime for tests. So in principle, this should make it a lot easier. They're ahead of the queue for any tests, and hopefully those test results come back quickly, because obviously staff are likely to have to self-isolate until it's been confirmed that they're negative. How that's going to work out in practice may well be another matter, and it'd be very interesting to hear from our listeners about what happens over the next couple of weeks, and if they do see a position where it becomes easier for staff to get tested and to get timely results.
Yeah, no, absolutely. Anyone out there who, sorry, Rebecca.
I presume that prioritisation didn't extend to care staff.
Social care staff are mentioned, but I don't think it's entirely clear whether they're going to be prioritised or whether it will be people in social care settings, residents, who are prioritised.
I think it sounds like one of those things that they've not quite worked out how it's going to happen in reality, but hopefully we'll see some kind of an improvement in the situation. But if anyone's listening, do get in touch with us if you have noticed better availability of staff testing. I think now's a good time to move on to kind of our second main topic of discussion in this podcast, which is a bit of an update really on what's going on with the workforce race equality standard kind of measurements, some of the work that's being done on diversity, and I'm really interested to hear from Nick, actually, who obviously covers this patch area for HSJ, on what's happening in this area at the moment.
Well, with the workforce rate equality standard, it seems like we've come to an important point in its life since it was conceived, in that you now have Yvonne Cockhill, who's retiring from the NHS at the end of this month. You have Habib Naqvi, who was its interim director after Yvonne was announced that she was leaving, now going to the Race and Health Observatory. So now those two leaders of the res are departing. You have Jenny Douglas-Todd and Mike Franklin, who were recently appointed as joint directors of equality and inclusion, potentially coming in with new ideas, maybe a change in direction, maybe taking on some of the things that Yvonne and Habib had been doing before, but it also implementing their own sort of flavor and ideas that they have coming into it. And it's important for one or two reasons. Firstly, for the two people leaving, as I mentioned before, but also the fact that after 5 years, it may well be in Prona's mind to look at the res and see, take stock of what has already been done, what has been achieved, the successes, maybe where it could improve, and then maybe look at maybe restructuring the way that they go about it. Do they appoint from within in terms of getting new directors? Do they appoint from outside? Do they maybe fold the res into a more comprehensive system in terms of reducing workplace inequalities? And then also this, the suggestion of Sir Simon Stevens stepping down, or is expected to step down next spring. That's a much broader question for the res, in that if the next person that comes in doesn't quite have the same sort of focus on something like the res, what is the res's future? So those are the kinds of questions that have been popping up a little bit about the res, and even more so with the fact that with the res having shown, slight decreases in some of its indicators, maybe not as much progress in certain areas, you then have to refresh it a little bit and think about how you can get those going in the direction that a lot of people want it to go into. Never mind the fact that the report that basically looks at the NHS's arm's length bodies came out the other week. My colleague Alison reported on that, and showing that there's been very little progress on that front. I mean, NHS England may well look the better of the ones that were reported on, but it's still not as, we still haven't really moved the needle as far as one would have expected. So really what I'm saying is that we're at a critical juncture really with the res, in that the people that come in next and the people who have joined in terms of Jenny and Mike, but also further people who may be appointed, where does it go from here? How do you make sure that the res is continuing to kind of reduce those workplace inequalities, as was the target from the start? And yeah, just continuing to kind of look at those questions from Prona's perspective as to how she then takes this forward as a NHS's Chief People Officer.
Isn't it a question of, I mean, how do you give the res teeth, really? How do you? It's an important tool to measure progress, but it doesn't actually. What does it do in terms of changing and increasing diversity across so yeah, should there be a question to answer about how you give the res teeth and actually make it have an impact?
I think it already does have teeth, in the sense that these 9 indicators do specifically look at areas of the NHS where there had been particularly difficult experiences for Black, Asian and minority ethnic staff. I mean, if you look at the res indicator for the proportion or number of people who are from BAME backgrounds who enter disciplinary proceedings, if you look at mandatory training, if you look at, those kinds of metrics, it does look at the processes behind those and trying to put them in a way that doesn't, disproportionately affect Black, Asian and minority ethnic staff. So it does have teeth in the sense that it holds a mirror to the NHS. I suppose where there are concerns is how to, first of all, stop maybe massaging the figures a little bit to make, one particular trust look better than it actually is. That's something that was brought up in an interview I did with Yvonne this morning, which will be published by HSJ at some point, in that she said that there were some trusts who are maybe, using loopholes as a way to kind of get away from reporting what is really truly the results of some of their indicators. So, for example, as I brought up before with entering disciplinary proceedings, if it's formally recorded by the trust, then it would go into the res. But if you package it in a different way and put it as, what she said was mandatory training, then you don't have it formally recorded, but it's still in basically the same, but with a different name. It's just packaged differently. So that's the first one. And then the second one is just overall the culture. As we all know, changing culture in such a large organization is one thing, let alone when you do it for an entire health service. So it takes a lot to try and get people to kind of all move in the same direction. And I guess it's only because that the res is the main focus for how we do that. It takes quite a bit of the stick, but ultimately it's only one part of a much larger issue, which is tackling race equality, and it will take a few more mechanisms than just the res to get that done.
I think one area where the res does have teeth is that it's very public, and I'm sure the arm's length bodies were suitably embarrassed from the story I did, showing that they were making very little progress. But unfortunately, although we cover that, and we cover things like the Birmingham area having very, very few board level people from a BMA background, zero, yes, very few. It doesn't get picked up by many other media, and I think that's a shame. And it would be great if every trust res report was read by its local paper and featured in their headlines, but it just doesn't.
I think that's a really good point. Maybe that says something to the sort of slightly worrying state of local newspapers at the moment in this country, which is really sad. But I think before we wrap up this week, I just wanted to ask Nick again, slightly on spot, around risk assessments. There were some interesting comments made by Joan Myers, who is the director and trustee at the Florence Nightingale Foundation, and she said that there were some adverse effects that have come out of some of the risk assessments. For example, staff being told because of certain characteristics, particularly kind of weight and BMI, that they were unable to work in clinical areas and unable to do their jobs properly. And I was just wondering what your thoughts are on this, and perhaps just the risk assessment scheme more generally.
Yeah, so the update really is that there isn't really one. It's more of a question of what now, given that the risk assessment deadline is long past. Trusts were given until the end of July to get them all in. NHS England made a big demand of trust to kind of get them all done within a certain time frame. The trust did that. How many got to 100%, we don't know, because we only saw the first window as we reported from that time. So now it's kind of like, okay, so now what? I mean, every now and again I've heard the phrase tick box with regards to risk assessments. It's just a tick box exercise, it seems. Does it have a tangible difference to the people who are being protected against COVID-19, the people who are more vulnerable to it with underlying health conditions or from a BAME background, so on and so forth? One trust director that I spoke to said that they hadn't heard about risk assessments in a while, so from NHS England. So that in and of itself suggests that it's not quite as much of a priority at the moment in terms of the next phase of it from the national perspective as it was at the time. Otherwise, you may well have seen another kind of request or another kind of directive in terms of making sure that these risk assessments were followed up on from when they were first told to get them in. And moreover, one thing that I'm quite interested in is how NHS England and NHS Improvement would quantify this as a success. I mean, yeah, you can have high rates of risk assessments being completed, but that's only one part of the story, because the other question is, how have they helped to protect staff from coronavirus, and in what ways can you really kind of measure that success in terms of putting them in a safer position to work? What strategies are you basically putting in place to make sure that the risk of coronavirus is mitigated as much as possible? I'm not saying that, risk assessments themselves are just the single antidote to eradicating the threat of COVID-19 to vulnerable staff, but it's an important tool. I think we can agree with that. And moreover, given how NHSE and I went about setting about a hard deadline to get trust to do it, are there not questions about whether it was successful or not? How can we know that it was actually an effective tool in terms of getting coronavirus mitigated in terms of the threat? And also more pointedly is that we don't actually know how many trusts ended up completing the risk assessments before the deadline, as I don't think NHS England has released that data. I mean, one source did tell me that they don't plan to make it secret, but where's the data to kind of show where we are with that? To more to your point about the adverse effects of risk assessments, it'll be interesting to see more about that because, as you said, the kind of effects of it may well be borne out in how staff would then work and are treated and so on and so forth. So it'd be interesting to look at that going forward into this winter period. But again, the lack of transparency on how many risk assessments have been completed, how this is being measured as a success, it makes it difficult to kind of answer a lot of these questions, and ultimately it leads to uncertainty about what the overall strategy is among staff, because if they don't know, then how would they know how the NHS is actually tackling this?
Nick, I don't know if you've come across this, but I noticed when I was looking at the Trust Board paper earlier today that they had a significant proportion of staff who declined to undergo this risk assessment. And I wondered if that was because of fear of the outcome and that it might affect where they could work, and potentially they may feel that their jobs are at risk if they can't work in the front line and can't do anything else.
Yeah, I can see that as being as an issue. There are people who will say that there's no point in doing a risk assessment, but then there are other people who say I don't want to do a risk assessment for fear that it will adversely affect my job. In certain areas, there are BAME staff who don't feel comfortable with the leadership that they work under, and if they do a risk assessment, what does that do for them? So yeah, no, I can completely understand that, and that's also another question to fold into the what's next of this situation, because ultimately coronavirus is not going away for a long time. The risk assessments is only one part of what is a much broader plan to help mitigate this problem. So there have to be questions asked about those who are declining to take the risk assessment, in terms of how can we make sure that they are not adversely affected by their decision not to take it, and also just give them the confidence that they are not going to be adversely affected, in the sense that they're not going to be put in a position in their job that makes them feel uncomfortable, or just other reasons that just wouldn't make sense.
Thank you, Nick. I think on that note, we're going to have to wrap up. But I think just for all listeners, watch out for Nick's interview with Yvonne Coghill, which hopefully will be published either this week or early next. And thank you also to Alison and Rebecca for joining me today on the podcast. And to remind listeners, the HSJ Health Check podcast is available each week on our website and across all main podcast channels. If you've enjoyed listening, please subscribe and share and rate our podcast to get more people listening each week, and get in touch if there's something you'd like to see us discuss. We'll see you next week. Goodbye.